Good afternoon. Dr. Randall Wolf here. Welcome to DeBakey Heart and Vascular Center. We're coming to you live from Houston, Texas Medical Center, and specifically Houston Methodist Hospital. Interesting presentation for the next 45 minutes. The rules are as usual. As you know, we have this webcast usually about once a month, first Tuesday, 5 p.m. Central Time. The staff takes a summer vacation for a few months, but we're back on now, and I put together really a presentation I think you're really going to like. And it's titled, Why Does the Minimaze Work in Patients with Chronic AFib or Long-Standing Persistent AFib? There is a perception out there that is promoted by electrophysiologists and some cardiac surgeons that the Minimaze only works if the patient has paroxysmal AFib. That means AFib that comes and goes. That's not true. The Minimaze works in patients who have continuous AFib, chronic AFib, long-standing persistent AFib, patients who are out of rhythm all the time. And it begs the question, why is that? Why does it work? So today we're going to explore why it works, and we're going to talk to a patient who had continuous AFib, had the Minimaze, and doesn't have AFib anymore. So Bernard Torrey will be introduced in a few minutes here. He's an audiologist in Chicago. He will tell you his journey of AFib and the path he took and where he is today. I would like to bring up a couple points before we get to that, and it's based on a couple slides from a presentation that I've given before. And I'd like to start with one. If we could go to the slides for a second. Hopefully now you see on your screen, it's a nerve issue. There was an article that came out not too long ago. Could zapping the spine help prevent AFib in high-risk patients who undergo heart surgery? And initially in their study it did. It's based on the fact that the heart has two systems. The heart has a system called your own pacemaker, which is the SA node. You have an AV node, and these nodes will keep your heart beating as long as you're alive. And generally they'll keep your heart beating at about 60 beats per minute. This is the intrinsic cardiac system. It's not, you don't tell your heart to beat, it beats at that rate. But as you know, your heart rate speeds up and slows down. Why is that? That comes from the extrinsic nervous system. These are impulses that start in the medulla of your brain, go down into your spine into areas called the sympathetic and parasympathetic systems. These are autonomic nerves. Autonomic nerves means you don't have complete control over them. These aren't nerves that go to a muscle, tell you to squeeze your hand. These are the nerves that make your heart rate speed up when you're watching a scary movie. Why should your heart rate speed up when you're watching a scary movie? You're sitting in a chair relaxing. But it happens. Or you're on top of a tall building and you look over the edge and your hands begin to sweat and your heart rate increases. You're not running. Why should your heart rate speed up? This is the autonomic nervous system. These nerves play a very important role in atrial fibrillation. And as you know, my approach has been a little different approach to AFib. It's a fundamentally different approach based on the fact that the nerves are on the outside of the heart, not the inside. So all the catheter ablations in the world aren't going to get these nerve endings that are mainly on the outside of the heart. That's important because when we say, why does the Minimaze work for chronic AFib? It's because we're attacking the nerves on the outside of the heart that are responsible for flipping the heart in and out of atrial fibrillation. The inside of the heart muscle, is just muscle. There are no nerves there. So it never made sense to me that we should be burning up the inside of the heart, which is essentially what's done with the alternative approach known as catheter ablation. I'm going to step down to another slide here for a comparison. This slide shows, let me make sure we're in presentation mode here. This slide shows catheter ablation, Minimaze, and convergent procedure. Some people confuse convergent with Minimaze. Convergent is where catheter ablation is done and the surgeon makes an incision below the xiphoid to access the back of the heart. Is the left atrial appendage electrically isolated in catheter ablation? No. With convergent? No. With Minimaze? Yes. Blood thinners can be stopped after the procedure. Catheter ablation? No. Convergent? No. Minimaze? Yes. Are the nerves isolated? Catheter ablation? No. Minimaze? Yes. Convergent? No. Is catheter ablation required? Well, of course it is for catheter ablation. It's also required for convergent. So those two procedures are totally dependent on a catheter ablation, whereas a Minimaze is not. And lastly, one more slide. Some other things about the Minimaze versus convergent procedure, or a totally thoracoscopic maze, or a minimally invasive Cox maze 4. These are some different surgical procedures. The heart-lung machine, not required for Minimaze or totally thoracoscopic maze or convergent procedure, but is for the open heart minimally invasive Cox maze 4. Do you have to give a blood thinner? Well, you have to if you use the open heart procedure. Catheter ablation is not required on any of these except the convergent. Is the ablation transmural? In other words, does the line go all the way through the heart? It does for the Minimaze, it does for the totally thoracoscopic maze, it does not for the convergent procedure. Now the little nerve endings on the outside of the heart are very important. That's where these autonomic nerves go into the outside of the heart. And I test those. They're called ganglionic plexi. Are those tested with the other types of maze or the convergent procedure? They are not. But with the Minimaze, these nerves are these autonomic nerve endings are tested, ablated, and then tested again. And that's why I think the Minimaze works in patients who have continuous AFib. Now, during this presentation, if you have a question, Bernie and I will attempt to address it live. As you can see on the screen, you can go to pollev.com, enter DeBakey, and then respond to the activity. Or if you're on your phone, you can go to text. You go to 37607, text in your message to text DeBakey, and then text in your message. So in the little box you put DeBakey, and the text spot is 37607. You can ask the questions now, and we'll line up the questions. We'll probably take them in order in which they are received. So don't wait till the end of the hour. If you have a question about AFib, if you have a question about for me or for Bernie, please again text to email respond to pollev.com on your computer. /DeBakey, or if you're on your phone, you go to 37607 and then text in DeBakey and then join and then text your message. As I mentioned, I'm joined today with a patient from Chicago, Illinois. He's a very renowned audiologist in Chicago, and I think the best thing to do is open the floor to Mr. Torrey and let him tell you his story. I may interject if I think it's appropriate at times. But Bernie, thanks for joining us for this webcast. People not only listen to these live, they also listen to these later. So it's important information. We appreciate you taking time out of your busy audiology practice in Chicago to talk a little bit about atrial fibrillation. Welcome.
Well, thank you, Dr. Wolf, and I'm honored to be here. it was kind of humorous when I asked you why you picked me. You said, well, because there wouldn't be any dead air. And at dinner in Houston after my surgery, you said that I was similar to my daughter, only a lot more loquacious. And I guess that means I talk a lot. But as an audiologist, I talk distinctly to people who don't hear well often. So I hope everyone can hear me now. And if you can't, then just call me and we'll arrange for you to come see me. And I'm actually in LaSalle, Peru, in Ottawa, Illinois. We're about 65 miles west of Chicago. But doctor, I found you through one of my patients. And you know, there's a Mamma Mia song called Take a Chance on Me, but very early into my research, I could see that you were not much of a chance. You were the sure thing, the one and done. And my patient, John, who I'll call him John, big gentleman from Henry, Illinois, farmer, 86 years old, says, I'm going to Houston, Bernie, to get my life back. I said, John, what are you talking about? He goes, yeah, well, I can't get to the mailbox and back. Well, he's a farmer. His mailbox may be a mile away, but I didn't think it was. He meant that he's out of breath totally by just walking to the mailbox, and he can't work anymore. He goes, naturally, my son does the heavy work, but I always work a full day. Now I can't. He goes, I have a friend who went to Dr. Wolf, and this is what happened. So he went down, had his surgery, and he's back working, doctor. And so you have another one of your successes. So that started me on my road of research. And I called, and I talked to my cardiologist in Joliet, Illinois. He's like, no, Bernie, just take your medicine. I'm like, well, Dr. Wolf says, you know, you have still a 40% chance of a stroke if you're on blood thinners and if you still have atrial fib, which I had constantly for 9 years. In the first 4 years, I was under 65 years old, and my other doctor friends says, well, you know, we kind of think you should be on blood thinner, but you don't have to be. But once I hit 65, all my friends arm twisted me and said, well, you got to be on blood thinner. I said, well, okay. But, you know, I'm an active kind of person, whether it's golf or theater, stage construction or whatever. I'm always helping friends and family. So anyway, as I found out more about this, I said, well, I don't want to have a stroke. And I would like to have more information. And I called Rush Press St. Luke's, and I called Chicago area, and I called New York, and I called LA. And they all said, well, yeah, we kind of do something like what, you know, Dr. Wolf's describing. And I said, oh, well, okay. Someone's talk about under the breastbone, and they go, and I go, how often do you do that? They go, well, a couple times a month, maybe. And I'm like, oh, okay, thank you. Because I had found out from watching, you know, the webcast just like this, the Dr. Wolf does 2 on Monday and 2 on Wednesday. So I said, this is the guy that you want to have this done with if you have a person of this nature who has this experience, who developed the technology. He is the person who designed this procedure for going in thoracically and going down and making the proper ablation on the outside of the heart, which makes a whole lot more sense than trying to burn from the inside. Since Dr. Wolf has told us several times, there's no nerves except the AV node to attack on the inside. And the only time you'd want to do that is if you're going to have a pacemaker, because there were no other choices. Well, it seemed that a lot of patients who had catheter ablations that didn't work, they didn't even offer it to me because I had back 9 years ago. I don't know if at Rush in Chicago it wasn't considered something that you would automatically do, but they didn't even offer me catheter ablation. They just told me go home, take my medicine, because I was cardioverted a couple times, which did not work. And then so I'm back in consistent, you know, AFib. But, you know, personally, I wasn't bothered by the symptoms. I didn't feel the swimming in my chest. I didn't get all that out of breath when I go jogging or golfing or in the heat and, you know, 18 holes in a 90-degree day. And I thought, well, I'm getting a little older, so I guess that's why I'm out of breath. But now that I've had my procedure with Dr. Wolf, I'm not out of breath, and I have a lot more energy and a lot more zeal for life. And I think it's the anxiety level is gone, worrying about this, and so that makes you feel a lot better.
Well, do you think part of it, Bernie, do you think part of it is the fact that slowly over time you may lose some of your breath? It doesn't happen all of a sudden, and slowly over time you're not quite as active, so you kind of forget how active you were?
Absolutely. You start running up a staircase after your friends and the kids, and you're running up the staircase outside at Starbucks State Park, and all of a sudden you can't make it very far before you have to stop and sit down. I'm like, oh, I really must have a serious heart issue, which at the time, a few years ago, I checked out and they said, no, you don't need stents, you don't have other cardiovascular disease like my father did. My dad had a heart attack when he was 50 years old, but he was an old Italian with a big barrel chest, and of course they ate a lot of fried chicken and red meat and pasta, and didn't exercise and didn't take care of themselves. So that was often the issue. But I was determined in my life not to have that kind of a problem. So I had always routinely tried to keep my weight, in line. I mean, I weigh 150 pounds, and I think when I graduated high school, I weighed 140 pounds. So, I mean, I worked on that and to try to stay in good shape. And then all of a sudden I'm hit with atrial fibrillation. And my story as to how that happened, Dr. Wolf is aware that, 10 years ago, I was working with an ear, nose, and throat clinical practice, and they had a doctor there that, in my opinion, was just not the kind of person I wanted to be along with. And so he started pushing me out and tell the hospital that I was, selling hearing aids. People didn't need them. I go, well, doctor, we have a 45-day trial with the money-back guarantee. But long story short, the hospital said, Bernie, there's nothing we can do. He doesn't want you anymore. He wants you out of the practice. I said, fine, I'm gone. See you later.
You had a lot of stress.
Yeah. Oh, yeah. So I think stress was the key, as you and I've talked about. And I think stress in our American society is why it's going on. I know there was a female cardiologist. I watched one of her webcasts from, I think it was UT. And she was reporting that anybody over age 65 now in America has one out of 10 people over 65 have atrial fib. And she went on to say that the babies born today, by the time they're 65, it's going to be 1 in 5. So this is not a benign disease. This is a disorder that people like Dr. Wolf have taken on straight, grab the horns and taken care of this issue. And so many other people in medicine, who don't do this procedure, don't recommend it. And that's a great disappointment to someone like myself, because I think they probably have lists and lists and lists of patients who are on blood thinner who don't have other concomitant problems that would create a comorbidity of not having this procedure. They don't have cardiovascular disease. They don't need mitral valve. They don't have an aortic aneurysm that was repaired, and there's not scar tissue in the back of the heart to prevent Dr. Wolf from doing this. And they still don't send them. And it's just unfortunate.
Let me interject here just for a second. Again, we're starting to get questions coming in, which is good. If you look at the top of your screen, I think you'll see it now. Is that right, Mr. Producer? George, can they see it now? Yeah, give me the thumbs up. If you're on the computer, pollev.com/DeBakey. If you're on your phone, 37607, then type in DeBakey, and then you'll get in to join and you ask your question. I want to take one of the first questions right now. The question is, can catheter ablation weaken heart and lead to congestive heart failure? There aren't any studies that specifically address this that I know of, but we can say this in general. If the heart stays in AFib long enough, there is a much higher chance of heart failure. To give you an example, what we do in the lab with an animal, if we want to simulate heart failure, we rapidly pace the heart of the animal, and that will produce heart failure. So the same is true with AFib. If the response of the AFib is a rapid rate of the heart, over time that will lead to heart failure, decreased ejection fraction, normal ejection fractions 55, 60, 65. Not unusual to see some heart failure with AFib and a reduced ejection fraction in the 30 to 45% range, sometimes down to 15%. Now, is it the catheter ablation per se? No, I think it's more the catheter ablation that fails. So the catheter ablations take place in the atrium, which doesn't weaken the heart that much, but it scars the heart. It doesn't decrease the function as much as the rapid rate. So I think it's more the continuous rapid rate over a period of time that weakens the heart. But as you know, if someone, I had a patient here not too long ago from Long Island who'd had 6 failed catheter ablations and multiple cardioversions that were unsuccessful. So all that time, that person was out of rhythm and the heart was getting weaker. So the fact that interventions were done that were unsuccessful is not good for the heart, because you have an abnormal rhythm for a longer period of time. But I'm not sure it's the catheter ablation per se. Bernie, back to your story. To move along, it was what? You came to Houston a year ago?
In November, I think. Yes, almost to the day. It was November 8th that you did surgery.
And we called it we called it chronic AFib, which means it's been several years. All treatment's been given up except to control the rate. That's chronic AFib. That's where you were.
I'm regularly irregular, and then they had put me on diltiazem just recently, like within maybe 2 years before I saw you.
To slow the rate.
My blood pressure was up a little, and my rate was high. So the cardiologist in Joliet said, "Yeah, you should be on this." I said, "Okay,
that's understand." And that's appropriate. That's appropriate.
Yeah, and I understand that. I do, but then I didn't understand why I had no other options until I found this, and as you know, the website and also the Facebook tells people like myself, be your own advocate. Please look into this. You're going to educate yourself to the point where all of a sudden it makes a little sense. That one and done makes a whole lot more sense than having 4 or 5 ablations that didn't work, and then continuing to do that, or doing nothing and letting it sequence to where, you know, your atriums, you get an enlarged heart, and then that's one of the issues where you can't then have a Minimaze, or you have other issues to where the heart has been damaged. And I was not about to let that sequence of events occur in my life. I wasn't going to wait until I was like John, who couldn't walk to the mailbox and back.
So when I found out, you came to Houston a year ago. You were here a couple days before the procedure. Tell us a little bit about your journey here and how long you were here and how you did.
Oh, okay. Well, when I got there, I had never found or seen such kind, compassionate, continuous care as I arrived in Houston. And I know there's a Southern charm to be spoken of, which doesn't really occur up at the Yankees here in Chicago or New York. But I mean, even when I checked in to the hotel, the doorman asked me why I was here. I said, well, I'm going to see Dr. Wolf. He goes, well, I've known a lot of patients, and they're all very pleased with Dr. Wolf and the DeBakey Heart Center. I said, oh, good. He goes, what can I do for you? And you know what? He meant it. He wasn't just saying that, being polite. He meant that. He carried my bags into the hotel and up to the desk so that I didn't have to handle my luggage. And my wife and my daughter was with me because they were my support structure. So once I was here and I met you in the lobby of the Marriott at 8 o'clock in the evening, which I thought was interesting. But then I found out, of course, you go home sometime, maybe I'm telling your secrets. You go home and then you come back on Sunday and you have to see your patients the night before because surgery is early in the morning. But continuing with the nurses that checked me in and the anesthesiologist who talked to me in the morning, and of course yourself having explained things so thoroughly and giving me such reassurances through my whole journey. And Dr. Wolf, that's why I ended up here, because of you. Because I mean, when you listen to the webcast and you listen to you, I watched your surgery video, which I know is probably a training video for physicians, and listening to your narration gives someone such a reassurance. You're there with your finger in the opening, and you're saying, "Now, doctors, there's a nerve here. Can you see it in the fat? We must just make sure we don't interrupt that. We want to just move it digitally back to the lateral portion so that we don't cause the patient post-operative pain." I'm like, this is my guy. This is the kind of person who I want to put my problems in his hands, and my life in his hands. And I know there's been no mortality with the surgery, and I think that when you listen to why and the things that are done, there's just no other reason or no other avenue that makes any sense at all except the Minimaze.
How long were you in the hospital?
4 days. And then when I got out of the hospital, Deb and Ashley and I stayed in Houston and enjoyed the museum and the food and things, because I wanted to get my stitches out and my chip in about 10 days afterwards, I think. And of course, you know what else we got to do together during that time. I won't tell everybody that, but it was a very wonderful, nice, hospitable thing. And then I was back home and in the hospital.
Were you in rhythm then? Were you in rhythm then?
I was in rhythm, and then you had me on medications, which you described as tabling medicines, for a few months. And by February, I was pretty much out of rhythm most of the time. And then all of a sudden, by the end of February, I was out of the rhythm 100% of the time.
You mean in rhythm?
And you
in
referred
rhythm.
to this.
Yeah. And now you've been off all medications for how long now?
Since February of 21.
Since February 21.
Yeah. So I mean, surgery date is a year. So November, December, January, February, I was on medicine, and I was out of rhythm, in and out. And then since February, no more AFib at all. And of course, I've got the Apple Watch that I can check myself, and my blood pressure is back down. I think it's like 124/78 or something. And I'm in rhythm. I'm regular, as opposed to irregular or regularly irregular, as it can be described. So I have had no AFib, and I feel fabulous. And it's
have you been back to see any of your doctors yet?
Oh, I have. And the doctor from Joliet says, I have never, ever had a patient who had AFib for 9 months and
no,
for 9 years.
9 years.
9 years, and who has gotten out of AFib. I said, well, doctor, do you see what I'm talking to you? And I had given him the YouTube websites and things that I had been watching. And I'm sure he looked at some of them. Because when I came back to him for a checkup, which probably would have been 6 months after I was out of rhythm, back in rhythm, he was amazed. He was totally fabulous. Flabbergasted. And I says, okay. I says, doctor, you should be lining up all the patients like myself. But I don't know if that happened. Which is,
maybe not.
Yeah, maybe not.
Maybe not.
I mean, we know, and from your, what is her name who does your website, who's so gracious on the webcast?
Sandy Schremeyer.
Yeah, so when Sandy explains what she had run into and why it wasn't explained to her until she found out herself, I think most of us are in that ballpark.
I'll interject again. If you'd like to ask a question, we'll have some time for some questions. You can text DeBakey at 37607, or you can use your regular computer, pollev.com/DeBakey. I'd like to go back to the slides for a minute, Mr. Producer, and I got a slide up here. And it talks a little bit about why the Minimaze might work, and also there are a couple pictures on here. One, the top picture shows a picture during the procedure, and I don't know if my pointer shows up on top there. It may not, I'm not sure. But it shows the device that we developed that goes around the left atrium, and you can see clearly there the superior and inferior pulmonary veins, and the clamp is inside of that, and that happens to be right where all the ganglionic plexi are. So in a way, we got a little bit lucky when we developed the clamp. The clamp goes right where the nerve endings enter the heart. On the bottom picture is a different patient, and to the right of that picture is the left atrial appendage, and that's to the right of the white clip. To the left of the clip is the left atrium and left ventricle. So now with the clip in place, the left atrial appendage, which is to the right of that white area, no longer communicates with the heart, which is on the left side. The clip, the AtriClip is what I use, is 100% effective in closing the space between the left atrial appendage and the left atrium. The left atrial appendage used to be called the left atrial appendix. Now you're all familiar with the appendix that emanates off the colon, but this little area on the heart also used to be called the appendix. It's important in the formation of the heart. The pulmonary veins then grow into the heart and push this area, the back of the left atrium, out of the way, and that becomes the appendage, or as I said, used to be called the appendix. It's been known for many, many years. It's the source of blood clots in patients who are in AFib because it's a cul-de-sac, it's a dead end. And when blood slows down, it will clot. Doesn't matter what type of mammal you are. If your blood slows down enough, it will clot. Now, if the clot were to stay in that little appendage, that would be okay. But unfortunately, what happens sometimes is it breaks loose and is ejected by the heart, and that blood clot goes out into the aorta. And one of the first places it can leave the aorta and go into the system are the arteries that go to the head. And that's why there's this association of stroke, as Bernie mentioned. And it is significant. I've had many patients who presented with a stroke. One fellow was doing ballroom dancing, 55 years old, and he passed out. They took him to the emergency room, they worked on him, and then the emergency room doctor came out to the wife and said, "How long has Harry been in AFib?" And she said, "What are you talking about? What's AFib?" So some people present with a stroke, unfortunately, and that's the first time they find out they had AFib. And they had a stroke because a blood clot came out of the appendage, was ejected from the heart, went to the aorta, and then up to the brain. So an important part of the Minimaze is to close that appendage. Now, an advantage of closing that appendage, in addition to getting people off blood thinners, is it decreases the risk of stroke dramatically, as Bernie mentioned, from 60% with blood thinners to a 97% reduction in stroke with the clip or closing the left atrial appendage. In addition, sometimes the left atrial appendage contributes to the AFib. This clip electrically isolates the appendage as well. So not only does it close it off, it electrically isolates it. In contrast to the Watchman device. Bernie, did they ever tell you about the Watchman or recommend it to you?
Well, when I started my research, my sisters, Julia and Patricia, naturally are concerned that I was going to go and have something that was very serious. I mean, it is heart surgery, to alleviate a problem which in their mind they couldn't see that I was having the issues that some patients have. I still was, doing a lot of my normal daily activities. And Julia brought that up. She goes, "I just read an article," because they must have started looking into it for me. "I read an article on the Watchman, Bernie. Why don't you look into that?" And I said, I already had the answer that you all had provided. I said, "Joel, the Watchman can be fine for some patients." I said, the inside of the heart and the opening to the atrial appendage, if it's nice and round and you have a cork like Watchman that's circular, then it'll fit just fine. But many of the appendages are pear-shaped or oval-shaped, like your ear canal. Some are round and some are not. And the Watchman may not fit well, it may leak. And besides, it doesn't take you out of AFib. It just helps prevent the stroke.
Yep,
but you still could have an issue with atrial fib that could cause damage to your heart over the years, and that leads you into other catastrophic circumstances which could end your life pretty fast. You could fall down and hit your head. Yeah. Like I just told Doctor yesterday, this Saturday, I was helping at the stage at the college. They're going to do a stage production. I took a header off a ladder and I scratched my nose and I hit my head and I hit my elbow. And I'm so glad I'm no longer on Eliquis, since you took me off Eliquis before my surgery. So it's been over a year.
Yeah.
So I could have had a catastrophic event just trying to help out the college kids do their show. Yeah. It could have killed me. I could have bled to death right there, and they would not have been able to save me. If I had a brain bleed, because what is the half-life of Eliquis? Is 3 or 10 days.
To your point, there's a fellow I saw in the office about a year ago. He came in, had a ball cap on, and sat down, and I looked at the notes, and I said, "I saw you 3 years ago." He said, yes, you did. And I decided just to stay on blood thinners. I didn't want the procedure or anything. I didn't go for catheter ablation, just stay on blood thinners. And I said, why are you back today? He said, well, I was up on a ladder and he fell off. He hit his head. He developed a bleeding in his brain. He had emergency craniotomy or surgery on his head. So he took off his ball cap. He had this big incision coming around where they opened up his skull to get the blood out. He had a stroke, but fortunately recovered for the most part.
Sure.
And he said, Doc, I got to get off these blood thinners.
Absolutely. It makes all the sense in the world.
You know. So, yeah,
my neighbor, when I was first married in St. Charles, a big gentleman, wonderful man, and he was in his 50s. He bumped his head getting in a helicopter. And then, later that night, they rushed him to emergency. He had passed out and he had a hemorrhage. And they saved his life. And I, of course, at the time, not aware of anything like atrial fib or whether he's on blood thinners or not. But, I mean, this can happen. I mean, you can have a brain bleed. You can have a GI bleed. And just the fact that, if you had a minor car accident, you could bleed out. I mean, and the 40% chance of a stroke scares me to death. If someone told you that in the next 5 years, you have a 40% chance of an auto accident that's going to put you in a nursing home for the rest of your life, would you go and drive? I wouldn't.
Yeah.
Yet I was told to go about my life in a normal manner, even though I had a 40% chance of a stroke, being on blood thinners and still being on atrial fib. It made absolutely no sense to me at all. And I wasn't going to have other ablations. Well, first of all, they weren't offered to me, but even if I was new to atrial fib and they offered that, when you start to research and see how often it doesn't work.
Yep. I talked to a patient earlier today. It's his 1-year anniversary, like you. He had paroxysmal AFib, so his AFib would come and go. He had not had ablations. He had not had cardioversions. And he said, why should I go the ablation route if I can go one and done? So he had it a year ago. He's had no AFib. He's off all medicines. He said he feels so much better, one, because he's off the medicines, but two, because he doesn't worry about it anymore. He's back to his regular life. He doesn't have that hanging over him every time he's thinking about going on a cruise or going on a vacation or going somewhere where maybe medical care is not accessible. He doesn't worry about that anymore. Does that ever cross your mind?
Absolutely. Deb's mom, my wife's mother, often had a tachycardia. I mean, I remember us flying when Ashley was just born, so that's 29 years ago, flying to Las Vegas with the family, and the baby was like a year old, so we're going to have a lovely time, first time traveling. And we get to there, and Dad leans out the hotel down. We're at the pool. He goes, Mother has to go to the hospital, and we all knew what it was. She had another episode of a tachycardia. Yeah. So, and not being very knowledgeable at the time, I don't know if she had atrial fib or not. She had previously had open heart surgery, so I bet she had atrial fib or something along those lines.
Likely. Yeah, that's most likely. So again, the Watchman device does not electrically isolate the appendage. The clip does. One of the questions that came in, it says, do the clips come in different sizes? And the answer is yes. The sizes for the clips are 35 millimeters, 40 millimeters, 45 millimeters, and 50 millimeters. And really what we're looking at is the base of the appendage, not how long it is, but how wide is it at the base, because that's where the clip goes. And in my experience, the 35 to 55 millimeter sizes fit everybody. So we measure the size of the base at the time of the procedure and then choose the appropriate size clip for the base of the appendage. I also wanted to ask you what you think is best for patients, where patients should go to get more information. You did a lot of homework. You're a professional in the medical field. You know a lot about this, but a lot of people don't. And you know this because they're your patients too. What are your recommendations for someone who has AFib? Maybe they've had an ablation, maybe they haven't. Maybe they've had cardioversion, maybe not. Maybe they've been told like you, there's nothing else we can do for you but take medications. What are your recommendations, Bernie?
Well, I think, Dr. Wolf, that there are a lot of patients like me who have been told exactly that. And once I found you on the webcasts, which we're doing right now, and that they're available on YouTube going back for years. I mean, and you can see 6 or 8 or 10 or 12 in a row if you'd like to. And then I found, of course, the video for the surgery, and I watched that about 9 times. And again, your reassurance of your narration is what sold me on the fact that this information was about as legitimate as could ever be presented, and the statistics backing it up were also presented. You know, when you were talking sometimes with pipes and plumbing, you know, from DeBakey, and your associate Alan would converse with you and ask you questions, and at times they were talking about the variations and occurred in this as a relatively new procedure as he was presenting it. I was like, I found out so much information on YouTube, and then I went to your website, and you click on further videos there, and then listening to Sandy and listening to other patients. Of great interest was the one gentleman who was an airplane pilot and his aircraft business, and he was a professional pilot his whole career, and he was, I think, in his 70s or maybe in his 80s now, so he didn't need to fly professionally anymore. But of significant importance, and everyone listening, understand what I'm saying to you. This is a cure. This is not a treatment. The FAA does not give you back, if you're an airline pilot, and I have several of those patients too, the FAA does not give you back your ticket to fly professionally in the airline industry unless you are cured of atrial fib. Because if you have atrial fib and you go for your annual medical or whatever it is, and they discover you have AFib, you cannot fly anymore. You lose your ticket, you lose your medical, as they say. And I'm a low-time private pilot, and so with me having AFib, if I wanted to go and fly a little bit, I wouldn't have passed my medical. And now I'm cured, and if I wanted to do that, I could go get my medical updated. And even in the insurance industry, they need to realize this is a cure, so that if they tell you, someone, that you're uninsurable for your life insurance because you have AFib, that's just not true if you've had the Minimaze. And that is a startling, striking, between the eyes fact that the FAA will get back your pilot.
I noticed for some time that patients would get back in rhythm similar to you, but maybe not in as good a shape as you have been. And they said, gosh, doc, I feel better than I have for 10 years. And I would say to myself, well, you're back in rhythm, but best you felt in 10 years? And it dawned on me after a while that I think what's really going on is half of it's getting in rhythm, and the other half is getting off some of the drugs that slow not only your heart down, but they slow you down. Now, I'm not sure you didn't have too much trouble with those medications, but you weren't on high doses, I don't think.
I wasn't on amiodarone until after the surgery.
I'm talking about the calcium channel blockers, the beta blockers, the sotalol.
The only thing I had was diltiazem, but it was 60 milligrams 3 times a day, and for my rate control and for my blood pressure, and that's the only one I was on. And I wasn't on aspirin therapy, and of course I was on at first Coumadin, and then switched over to Eliquis. Yeah. And
well,
those two
things. It's also true that once the heart's in rhythm, your blood pressure is usually better. And closing the appendage helps that too, if it's done with the clip. But the Watchman, there's a study done that showed if you close the appendage with the Watchman, the blood pressure didn't go down. But if you close it with the clip, it did.
Is that because of the enzymatic contribution of the left and right atrial appendage? And then when you change that, then it seems to have a beneficial effect.
Yeah, it's the hormonal component of the appendage, and that has some degree on raising your blood pressure. If you put a cork in, like the Watchman, all that hormonal stuff is still going on. But if you close the appendage with a clip, the distal part of that appendage atrophies and just becomes a little glob, and you don't have that hormonal output anymore. That's the theory anyway.
And enzymes, I mean, not that I'm medically trained as you are, but enzymes in the body is still a great mystery. I mean, some of the contributions and the reasons why things, well, some people fight off cancer, some people cannot. I've had a lot of skin cancer, but, you know, my mom did. She was Irish and English and German. My dad was Italian, and I got my mom's skin. But, I mean, these contributions in our body are difficult to understand. My sisters have had no skin cancer. I probably had 50 surgeries.
Autonomic nervous system is a good example. Bernie, it's been a pleasure talking with you. I didn't ask you this before the program. Sorry to ask you online. We don't give out telephone numbers for anybody, but we do share email if you would like to. But you're a busy audiologist. You may not want to do that.
Absolutely. I don't mind at all. I love email correspondence with patients, friends, and family. And I won't now, of course, but I give my phone number out to a lot of my patients, because I want them to talk to me, and I don't mind at all.
Well, I don't want you to do that. I don't want you to do that on this webcast. But is it okay to share your practice email or something like that?
Sure. It's auditory, but it's spelled with my last name. So I thought that was clever at first, but now it makes it difficult for people to write out a check. But it's AUDITORRI@AOL.com.
Auditory,
so
TORRI.
AUDITORRI@AOL.com.
Okay, well, ladies and gentlemen, we really thank Bernard Torrey, audiologist from Chicago, for joining us for this webcast. If you have further questions, give us a call. And if you're interested in contacting about the Minimaze, you can go to wolfminimaze.com, wolfminimaze.com, and you can get information about contacting us. Happy to hear from you. Bernie, thanks again for taking a little time out of your busy practice. Have a good rest of the week. Everybody, we'll see you the first Tuesday in December, 5 p.m. Central Time. Until then, take care and have a good weekend.
Thank you, sir. Goodbye, everyone. Thank you. Bye-bye.